Welcome everyone to today's grand rounds. We're going to give everybody a minute or two to just enter as the session is starting. Okay, it's 8:02, so we're going to get started with today's Global Health Grand Rounds. It is such a pleasure to introduce today's session entitled The Mouth Speaks to Physicians, Integrated Patient Management. And we are very lucky to have three excellent speakers with us today. Jane Barrow serves as the executive director of Harvard School of Dental Medicine's initiative to integrate oral health and medicine. And she directs school-wide efforts in education, research, and clinical services that further the school's strategic goals for oral public health and also the integration of oral health and medicine. She works with an interprofessional team of faculty and staff, and her office strives to identify the burden of oral disease, educate an interprofessional workforce, reduce oral and other non-communicable diseases with shared risk factors. And their work really does strengthen health systems and improve the health of communities locally and around the world. Joining Jane is Dr. Donna Hackley. Donna is an assistant professor of Harvard School of Dental Medicine. Her training includes residencies in general dentistry and pediatric dentistry, as well as a master's degree in peace and conflict studies, as well as a master's degree in public health. She is the principal investigator for the Harvard and Brigham-led Human Resources for Health Rwanda project to launch the first and only dental school in Rwanda. And we are also lucky to be joined with Dr. Eleana Stoufi. Dr. Stoufi is a lecturer at the Harvard School of Dental Medicine, an honorary associate professor at the University of Rwanda, where she teaches the oral medicine and oral pathology curriculum. And since 2019, she has also been a member of the National Committee, the Greek Ministry of Health for Strategic Campaign Against Smoking, among many, many other responsibilities in Greece and beyond. She's the secretary of the Scientific Committee for the Greek Dental Association and a member of the Scientific Committee of the Greek Anti-Cancer Society. So we are very lucky to have the three of them join us for this exciting presentation. Jane, I'll pass it over to you. And I just one quick reminder to all of the attendees that the Q&A function is available at the bottom of your screen, your Zoom screen. So please do, as the presentation proceeds, leave questions for the speakers, because we'll have time at the very end to have a panel discussion and a Q&A. So thank you very much. Jane, over to you.
Great. Thanks so much, Amir. Well, we are absolutely delighted to be here and share with you some of our work. So let's get on to the next couple of slides, please. So today's okay, we'll jump right to it. Oral diseases and disorders are a silent epidemic hiding in plain sight. Our mouth is connected to the body, obviously. We use it to eat, smell, taste, breathe, smile, and yet many of us are affected by oral diseases and disorders, maybe suffering pain, and it's perhaps significantly affecting our quality of life and maybe exacerbating non-communicable or communicable diseases. 44.5% of the world's population is affected by oral diseases and disorders. It's the #1 category in the Global Burden of Disease report and has been for a number of years. And unfortunately, underserved communities are disproportionately burdened. If you're living in poverty, if you're an older adult, if you live in a rural area, certain races and ethnicities, you are likely to be disproportionately affected by oral disease. And what's really tragic is that oral diseases and conditions are largely preventable. If you are instructed in oral hygiene and have access to preventive care, you should not lose all of your teeth. You should not become a dentulous, even though most people believe that that is just a natural course, part of the aging process. Dental care often is excluded from universal health coverage. If you do a quick check, many countries' universal health coverage plans do not actually include dental care, even though they're called universal health coverage. The World Health Organization has made a call to action around oral health and dental care, calling oral health an essential component of overall health and wellness, and access to dental care a basic human right. So we have actually been doing a lot of work with the WHO team. And this is because, as noted, the oral diseases and conditions can have a significant impact on your quality of life and really does make a difference in your self-esteem, your employability. If you're suffering pain, you can't focus at work or at school. If you can't smile, you may not interact socially. You can't eat healthy, nutritious food if you can't chew. And then, as you can see, there are a variety of other associations here. Diabetes, respiratory disease, cardiovascular disease, and dementia in particular are big ones that are related to oral diseases and conditions. Next slide. And just to give you an idea, the oral cavity often gives us a clue to some of these diseases before you see them anywhere else. Early onset of diabetes, HIV, etc., often can be identified in the oral cavity. So understanding how to look in the oral cavity is very important for patient management. Next slide, please. So we have this huge burden of disease disproportionately affecting underserved communities. Who's looking in the mouth? Most member states, WHO, don't have enough dentists. There is a global work shortage. And I'm sure many of you in other professions see a similar situation in your own profession. So if we don't have enough dentists and we can't educate our way out of this problem quickly enough, it becomes critical that other members of the healthcare team have some foundational knowledge, that they know how to look in the mouth, they know how to talk to patients about their mouth and their oral health, and they also know how to talk to dental professionals and when to make a referral. Problem is, most health professions don't provide any curriculum to their trainees. Some programs, and we've done some studies on this, offer 0 to 4 hours. If you get any, that's about what you get. Many training programs have no content at all related to oral health. And so if you don't learn about it while you're being trained, maybe you think it's not important. Maybe you don't think about it at all. And you certainly don't have the language to communicate with patients and other providers when problems arise. Donna, next slide, please. And so this is how we tend to think about it, and I'm sure you all have seen this kind of pyramid in other settings. There's a huge quantity of care that's needed. Some of it very often, some of it not, some of it very costly, some of it not. But as we think about our work, we try to think about how we work our way up through the pyramid. How can we engage individuals in self-care? How can we educate individuals about oral hygiene? How can we work with community health workers? How can we work with schools, nursing homes, hospitals to incorporate dental care and oral hygiene into their standards? How can we work with physicians and nurses in ambulatory care settings to incorporate care? Things like a quick look in the mouth, things like silver diamine fluoride or fluoride varnish application, and then how do we create team-based approaches to more advanced disease that include dental professionals. Next slide, please. So our goal with our global health team really is to try to transform global health education and care delivery systems. We want to ensure that everyone has access to holistic care that includes dental care and in a way that doesn't lead to financial hardship. So we have an interdisciplinary team that includes not only dentists of varying specialties, but physicians of different specialties, nurses, nurse practitioners, epidemiologists, behavioral health specialists, pharmacists, and biostatisticians working on curricula and demonstration projects to figure out how can we do a better job raising awareness of oral diseases and conditions and incorporating therapies and preventive measures into standards of care across the board. We don't want to teach other people how to provide dental care or to become a dentist. This is really about enhancing patient management and patient outcomes, providing our peers and other professions some foundational knowledge so that they can do their jobs better and be more effective in helping their patients. And we try to do this in a contextually relevant way. There is not a one-size-fits-all solution. Next slide, please. So we organize our research and training around 5 pillars, and everything we do is done in an interdisciplinary partnership and community of practice. And education, if we have wonderful interdisciplinary education programs, we need to make sure we have clinical practices that support a team-based approach to care. And if we find that we're doing a great job enhancing patient outcomes and potentially lowering care expenditures down the road, we need to be evaluating that, publishing that, and getting the news out there so that health ministries, finance ministries become interested and understand the benefits of these different approaches and can incorporate it into workforce planning. And of course, like everyone else, we love new technologies like wearables and so forth and want to incorporate that into the work that we're doing. Next slide. So I'm going to go from the right to left, and I'll just touch upon these. I won't discuss every single one. I think for this group, our World Health Organization, WHO, Africa Mobile Health Initiative for community health workers might be of particular interest. We are working with WHO and some other stakeholders to create a mobile health platform training community health workers in foundational oral health so that as they work with their patient populations, they are talking to them about their oral health and providing some guidance on oral hygiene and making referrals as appropriate. Policy and advocacy in Rwanda with the University of Rwanda, the School of Public Health, the Ministry of Health, the Rwanda Dental Association, and a variety of other stakeholders, Tufts University. We worked on the first National Oral Health Survey to understand the burden and distribution of disease. That is now incorporated into the National Health Survey, and information from that survey is being used by the Ministries of Health, Education, and Finance for workforce planning, as well as the health delivery system in terms of where to locate people. Mexico, we worked with a consumer organization, the National University, the Dental Association, some public health experts to conduct a public health campaign around sugar-sweetened beverages and their impact on obesity, diabetes, and oral health. India, we worked with a variety of stakeholders around tobacco cessation and cancer prevention. So you get the idea that everything that we do is done in an interdisciplinary fashion, working with multiple stakeholders, trying to create an understanding of association between oral and other diseases, and then working with people in the policy world so that the evidence that we're working on can be translated into policy and make a difference at the patient level eventually, we hope. And then we love data in our group. We do a lot of health outcome and cost studies. Periodontal disease is an inflammatory disease, a lot of associations with diabetes and hypertension, dementia, pregnancy outcomes. So there's a huge body of literature around that, some of it by us, as well as many, many others. Emergency department utilization is a huge issue. In the United States, $2 billion is spent on oral care in emergency departments. This is not unique to the United States. In Rwanda, a few years back, some members of our team with others from HRH and the University of Rwanda took a look at emergency department utilization in district hospitals and found that dental emergencies were one of the top 3 or 4 reasons why people were presenting at the emergency department. And as I said earlier, given that most oral health problems are preventable, there's no need for these folks to have to go to an emergency room. Their problems should perhaps be prevented in the first place or treated in an outpatient setting rather than using the highly resourced emergency department that could be treating someone who needs to be in the emergency department. So we really need to change how we do things. Next slide, please. Just quickly, a couple of our demonstration projects. The Tisch brought together, matched up dental practices and primary care practices to try to create new clinical pathways. Our nurse practitioner dentist collaborative is actually based at HSDM. We have a nurse practitioner working in the dental clinic that's meant to close gaps in care and facilitate conversations among the team members, not to replace the primary care provider, but to give patients with chronic diseases an opportunity for an extra touch point in their care. And for individuals who haven't seen a primary care provider in a while or don't have one, an opportunity to have a conversation, as well as counseling about things like nutrition, behavioral health, smoking cessation, etc. And I just wanted to give a shout out. We had a global symposium on integrated care last year, and we had some really inspiring presentations from Dr. Mbaye from Senegal, who is treating diabetes patients and incorporating dental care into her standard of care, and Dr. Mokombe from Mozambique, who treats pediatric patients with rheumatic heart disease, also inspirational in terms of incorporating dental care into the work that she's doing. So we know that there is a community out there that is thinking about this, and we're always hoping to expand our community of practice to learn new and different ways of incorporating dental care into standards of care. Next slide, please. So the meat of the matter for today is our educational initiatives. We have worked on an online curricula called Smiles for Life. Dr. Hugh Silk, who's based at UMass, but also has an appointment with us at HSDM, is a family medicine physician and one of the principals behind this. This is targeted to physicians and nurses who are interested in learning oral health competencies. There are different modules. Donna Hackley, Brian Swan, Brittany Seymour also have contributed to this curriculum. So you can take a look if you're interested, something that can be done asynchronously. We were part of the Human Resources for Health Rwanda initiative. I'm sure many on this Zoom also were part of that, to create a world-class health professions education system for Rwanda. Dr. Banagwaho, who was the health minister at the time, felt it was critical for Rwanda to have a dental school as part of this initiative to educate professionals. And we worked with folks from the University of Maryland, as well as others, certainly many on the ground in Rwanda, to develop the plan for and implement the first dental school in Rwanda. And we collaborated closely with the School of Public Health, the nursing school, and the medical school. And like Harvard, the preclinical years for the dentists are with the medical trainees. So again, everything that we're doing is a multidisciplinary approach meant to raise awareness and promote integration of dental education and care delivery and financing in the policy level with other components of the health system. You see that in our work with the Health Advancement Initiative in Vietnam, and certainly with the University of Global Health Equity work that we're doing, which my colleague Donna Hackley will now discuss. Thank you.
Great, thank you so much, Jane, and thanks to everyone for being on the call today. It's great to have this opportunity with you. And yes, I'll lead us through the UGHE initiative and then turn it over to Eleana for some case presentations. And I wanted to give everyone a bit of a background, although my hunch is that some on the call may be very familiar, if not collaborating with UGHE. But back at the beginning, when Dr. Paul Farmer and Dean Abebe Bakali and the Vice Chancellor, who was Dr. Agnes Binawaho, were submitting the curriculum to be approved by the Higher Education Council, they knew the importance of physician knowledge of oral health. And it doesn't mean dentistry, but a basic working knowledge of oral health and some basic skills and techniques that could improve their practice of medicine. And so right from the start, the module of dentistry was part of the curriculum. And the first class entered in 2019, and they're finishing their 5th year right now, which is so exciting. And the pictures on the screen, obviously, especially those of you who have been to Barrow know, this is the drive into the campus on the top right, and then on the bottom right is the campus at twilight. The painting is of Paul Farmer, and there is a community down the road from the university and from the hospital called the MGH Center, Heritage Center, and they have a room dedicated to health and healthcare. And on one wall is a painting of a traditional community healer providing some sort of treatment and care to a child patient. And on the opposite wall is this beautiful painting of Paul with a tribute around him, as you can see, vases and flowers. And, you know, when I was there, they expressed to me how grateful they are that the university and the hospital have come to their community, and that with both types of care that they're receiving, they feel seen and treated and healthy and recognized. And they're very, very pleased that Paul and the university and the hospital have come to be. The bottom picture here is the picture of an Adirondack chair near Paul's apartment, where I understand that he enjoyed sitting and looking out over the valley across the way of which is the hospital complex. So while the curriculum was approved and the students enrolled for 2019, the dentistry module, as it's called, wasn't experienced by the students until their 4th year of training, which was last year. And in thinking of how, what was going to be part of that curriculum in terms of the actual content delivery, we know, as Jane just pointed out for us, the growing oral and systemic health connection. And Dr. Lisa Simon also touched on some of these ideas last week, which was also a terrific presentation. And I was thrilled again to see so many of our physician colleagues on the call and engaged and excited about what she was presenting. And we know oral disease is the #1 NCD worldwide. It's more than asthma, more than any other non-communicable disease. And you've probably heard it said that we can't drill our way out of the problem. Yes, a little dental humor. And it's true. We could never treat all of the disease that exists. And by the numbers that Jane just showed you, people just don't have access to care, and there isn't universal health coverage in most places. Although I have to say, those of you, who are familiar in Rwanda with the Mutuelle system, Mutuelle de Santé, which covers about 70+% of the population, at the universal health coverage scheme does include oral treatments and dental treatments. I know that the majority of the population doesn't realize that some oral health care is included in their medical insurance, but it is there. And but that's not the case in most situations. So the other thing is, Jane showed us the pyramid, the primary care health pyramid. And if we're not seeing patients until they already have disease, if we can see them at all, and even in the US, we often don't see children, although we're supposed to have a dental home and do the first visit by age 1, according to the American Academy of Pediatric Dentistry. The fact is we don't often see them when they're that small, and they're definitely seeing their primary care physicians from birth. So it's a great opportunity to engage some of the oral health education and principles and fluoride application and SDF applications, for patients and their families before they might find their way into a dental practitioner's office. And so when we were looking at UGHE, our big question, the curriculum was given to us, and what exactly were we going to teach and how were we going to teach it? And I can tell you that we had a team of so here's Dr. Eleana, the second from left. She's an oral medicine specialist. And then in the center is Dr. Michael Ray, our oral maxillofacial surgeon. And they were both part of the HRH team. So we had a good feeling and a pretty good understanding of the context of Rwanda. And joining our team was Dr. Samson Habaneza on the left, and this is Dr. Eleana Stoufi next to me. And they are actually graduates of the second class of dentists out of the University of Rwanda School of Dentistry, who are the dental surgeons now on faculty, on staff at Butaro Hospital in the stomatology department. So it was so rewarding for us to bring this team together and to be working with our former students now as colleagues to develop this curriculum. We also had on the team a wonderful oral pathologist from the hospital. We had the community medicine team, we have e-learning professors, and it was really a great effort last year. So we did a site visit in 2022, and for the year leading up to module delivery, which was last spring, 2023, we met weekly to, at every point, what content do I, as a physician, would I find valuable, and also that speaks to the approved curriculum at the Higher Education Council. Those were our two bases that we were trying to cover. Every decision we made was through the lens, through the eyes of a physician. And so it ran last year, and we're making our second iteration to be delivered this May. And our team has grown, actually. We now have a local oral maxillofacial surgeon on board. And so the students will rotate in two locations, Butaro Hospital and the military hospital in Kanombe, where the oral surgeon is based. We also have a physician dedicated to our module, a local physician, UGHE junior faculty. And we have, again, our oral pathologist and our e-learning faculty as well. So we're at the same time trying to be very sustainable and integrated with the community so that the module can continue, even if something like COVID were to pop up and we can't get the expat faculty over to Rwanda. But it's really a tremendous experience working with our collaborative team, really tremendous faculty. So our pedagogy means are didactic, right? We have lectures, and the majority of them are going to be given this year by way of recorded videos so that we can dedicate our class time to case discussions. We also use the simulation lab at UGHE, was beautifully outfitted, dynamite sim lab. We use the clinics, as I said, at Butaro Hospital and at the military hospital. And last year we did go on outreach, but that experience is likely going to shift over to the community medicine department and out of the dentistry module. The learning content, we basically had three chunks around which we aligned our teaching. And one is the basic anatomy, terminology, disease processes. I mean, you have to recognize healthy and not healthy. And if that, it just needs to be done. That's our foundation. So we spent a bit of time on that. With Michael, we and Samson, actually, we did a lot of essential oral surgical training. And I know Lisa spoke about this last week as well, managing infections, and proper referrals. Now that Rwanda is producing dentists and deploying them throughout the country so that they are accessible equitably throughout the entire country, how do physicians and dentists communicate with each other? What information needs to flow back and forth for the best treatment of the patient? We do teach how to give local anesthesia, and that is for two reasons. One, because they may well be able to take a biopsy out in the field and save the patient from having to travel all the way to the hospital for that, where it could be hours away. And for handling trauma, like soft tissue lacerations, you're going to get a better finish if you're not inflating the tissues with all the local anesthetic. And if you know how to give a block away from the laceration, you can get a better aesthetic result. the situation in Rwanda is such that I saw with my own eyes pathology samples coming in from the opposite end of the country by way of pickup truck, and there's also the possibility of moving them by drones. And the pathology department at the hospital is very strong. And they also have the option of communicating with pathologists at Dana-Farber and the Brigham as and Mass General, I believe, you know, in the event that there's a question or they'd like to discuss a case further. So it's a very, very strong protocol in place. And of course, then there's also Barrow Hospital and also hospital in Kigali that can offer treatment to patients if indeed there is a positive diagnosis made. And then our third chunk, which is by Dr. Eleana, was our oral medicine content, which includes a bit of what I'm talking about in terms of recognizing ill health in the mouth, determining when a biopsy might be indicated or other treatment might be indicated that is well within the realm of a physician to handle. So that were the three basic concepts that we have in our the content. So I thought you might get a kick out of this. This is our local anesthetic instruction day. And you can see here, Michael is injecting Eleana with a lower inferior alveolar nerve block, which I didn't want because I really don't like the block. He promised her he'd only use a little bit of solution, but he's been doing it for years, and he just was talking along and he gave her the whole carpule, and she was numb for about 3 hours. And here we have Michael demonstrating the maxillary infiltration on me. And I, look at the students, they're just amazed that it's not painful is what they're saying. And here you can see that those who were watching in this picture are here now practicing on each other. And I dare say they're probably some of the best trained physicians now worldwide in terms of oral health and being able to conduct a few procedures intraorally. So, and honestly, the day that I said we're going to practice on each other, they all ran out of the room. And it was about 20 minutes before they came back into the room and we got going. So, but at the end of the day, they weren't, happy to have each other, giving each other a shot, but they did appreciate the feeling of local anesthetic, because remember, most people haven't, even our students haven't had dental appointments before. And secondly, they said, we really learned empathy for our patient. Now we know how it feels to be afraid, and we're taking that with us, which I think is, again, such a tribute to what Paul wanted to teach to students, is really empathy for patients. And then lastly, they also said when I gave my first injection to my patient, I had good confidence because I knew how to do it. So that's why some of the reasons that we practice that on each other before we practice on patients. I did want to mention that especially where we're at Barrow, which is a regional center of excellence for oncology care, is that, lip and oral cancer is ranked in the report I was reading, it's ranked 16th overall. It can be regional, it can be higher than 16th overall cancer. It's very detectable, and it's detectable at early stages if we take a look. Most are not found until they're stage 3, which has a very poor prognosis by the time we get to stage 3. But if we can detect it earlier, it's very treatable. So taking a look in the mouth and identifying patches that look suspicious and then having a workup done can really be life-saving and something that can very easily be incorporated into medical practice. Here are a few examples of oral health and oncology, things that we have taught our students at UGHE. And so yes, how to recognize some oral cancers, how to recognize oral manifestations of systemic diseases. So we're not talking about dental diseases or periodontal diseases. And then we also, because we're in a place that's providing chemotherapy, we looked at oral effects of chemo and radiotherapy as well, and gave the students some examples of that. We did have the students do screenings at the hospital of the patients coming in for chemo, and we modeled our form after the form used by the National Oral Health Survey so that we could loosely draw some comparisons. We can't run a statistical analysis for a number of reasons, but to get a sense of how the patient pool we were seeing compared to what we found nationally. And we ended up screening, and this is thanks to Allison Beerling, who is also part of the team. And she prepared this slide for us. And we screened a total of 164 patients over about 9 weeks. And the students screened all of them. And then either Eleana or myself did a screening as well to confirm the findings and discuss anything the students found. And they have eagle eyes now, I tell you. And the one piece of data I thought I'd share with you is that the national data showed that 64% of the respondents had reported pain in the past year, pain in their mouth within the past year. And 46% of the patients that we screened at Butaro reported pain in the last year. And I would say to you, let's just call it 50% for the sake of discussion. If 50% of all of the patients had pain in the past year, we have to look in the mouth. It's not always a cavity. And if it is, what do we do about it? If it's something else, what do we do about it? Is it contagious? Is it cancerous? But having a sense of what's going on in there is so important and can really boost patient health and clinical outcomes. So thank you so much. And I'll turn it over to Eleana.
Hi from me. Good morning to America. Good afternoon from Athens, Greece. I will present some cases that we encountered while we were at the Butaro Hospital and University. We encountered many patients with teeth that needed immediate treatment when we did the oral screening, which, if not provided, could endanger the outcome of their chemotherapy by developing, for example, acute local or bacterial infections. Because though the immunosuppression, these infections could easily disseminate. We also came across patients that had oral lesions, benign or malignant, that had not been diagnosed because a routine oral screening prior to their admission had not been performed. The cases that I will present, I'll show you pictures which are representative, and they can come from my own archives to illustrate the case because appropriate consent forms were not available at the time. So please, Donna, move on. The first case, yes, it's a 5-year-old male child which was diagnosed with ALL undergoing chemo. Oral screening was not performed before or during treatment, but when we did the oral screening, we saw multiple, I don't know, can you see the pointer? Yeah, thank you, Donna. We saw multiple periapical abscesses with fistula secondary to advanced dental decay of primary incisors. At this point, we had to discuss with a pediatric oncologist and try to find the window between his treatment cycles that would allow us to perform the extractions without disrupting his treatment. Given the fact that patients come from areas far from Butaro, this was a very difficult procedure. Can we move on, Donna, please? Okay. The second case is again a 5-year-old male patient, ultimately diagnosed with ALL. Taking a detailed history, the parents reported that oral lesions preceded ALL disease diagnosis, but when admitted at the hospital, no oral examination had been performed again. Upon our oral screening, we found swollen gingiva. Can you point them out, please, Donna? Yeah. Easily bleeding upon probation, although his oral hygiene was relatively good, not justifying the clinical presentation. And we also saw extensive ulcerations at the lower gingiva. Remember, these are not the original pictures, with lack of inflammation. Both findings are very indicative of a blood disease such as leukemia. So maybe this child could have been diagnosed much earlier than when he did. So the third case, Donna. Here, these pictures are the actual pictures of the patient, because just last week the patient went back to the hospital and a consent form was signed by the guardian. So this is a 12-year-old male patient, again with a LL diagnosis. And our first encounter when we did the rounds and approached this boy, we saw that he had a huge swelling on the left side of his face, as you can see. And before he even opened his mouth for the screening, we were taken aback by a foul smell. The finding was not reported on his medical record. Next slide, please. Yeah. His record revealed that he had a LEL and he was being treated with chemo. He was coming every 3 weeks, and this was his 3rd cycle. And nobody checked his mouth during that time. Upon oral examination, we saw a necrotic lesion, as you can see, extending to half of his palate with bone exposure covered by necrotic pseudomembrane. We performed a biopsy, and the child was prescribed by the oncologist amoxicillin perox for 15 days. Unfortunately, the next day he was discharged, and we could not keep up a follow-up. Next slide, please. We'll show you the same child, the site where we took the biopsy and the outcome of the biopsy report, which revealed necrosis of epithelium extending to the bone with moderate inflammation. Next slide, please. He came back 3 weeks later for the next cycle of chemo, and he reported that he had not taken his antibiotic treatment. And upon examination, as you see, we saw that the necrosis had progressed tremendously. Half of the palate bone was detached, and there was communication with the sinus. We considered of performing a second biopsy, but eventually consulting with the oncologist in charge, we decided it would be better to have him transferred to the military hospital at Kigali at the oral surgery clinic. We connected the chief oncologist at Butaro with the oral surgeon at Kigali at the military hospital so the patient could get further attention. Unfortunately, my rotation at Butaro ended the next day and I left the country, so we do not know the outcome for this case. Next slide, please. This is the 4th and last case I'll present from Butaro Hospital. That's a 58-year-old male patient, HIV positive, under treatment, who presented with a parotid swelling at the Kigali Hospital, military hospital, that was present for 5 months, and it was rapidly growing. He was referred to Butaro Hospital from Kigali with a diagnosis of Burkitt lymphoma to be treated with chemo. An extraoral biopsy had been performed at the military hospital, and at the time of our examination, a month later, the site of the biopsy had been where the biopsy had been performed had not healed and it was infected. I'm sorry you cannot see the original picture, so you can see the extent of the lesion. The next slide is what we saw when we screened our patient. We saw a flaxion parotid swelling that was present, as he reported, for 5 months and grew rapidly. And our team thought that the histopathologic diagnosis was inconsistent with the clinical presentation. Besides the extraoral swelling, intraorally, we saw an extended ulceration similar to the one in the picture, perforating the buccal mucosa, anatomically located around the duct of the parotid gland. In collaboration with the oncologist in charge, we performed an intraoral biopsy this time, and the report we got back was salivary gland adenocarcinoma poorly differentiated, a diagnosis that was confirmed as well at Brigham and Women's Hospital. The intraoral incision healed within 10 days, and of course, the treatment approach had been redesigned. At the next slide, I would like to point out how important it is for the medical physician to have the basic knowledge of oral diseases in order to recognize the primary lesions in the oral cavity and maybe appropriately handle them. You can see on that table a comparison of the biopsies performed. The first biopsy done at Kigali Hospital was taken in April of '83. The second biopsy performed by us a month later, May of '23. The first biopsy was taken at the skin area of the right parotid gland extraorally, while we took the biopsy from the buccal mucosa area of the right parotid duct, and it was, of course, intraorally. The histopathological report came back with a diagnosis of a Burkitt's lymphoma at the first biopsy and a poorly differentiated adenocarcinoma at the second biopsy. And as I said, the follow-up indicated that showed that the extraoral incision on the skin was infected and hadn't healed for a month, while the incision we took intraorally healed within 10 days. I strongly believe that the curriculum of the medical students should have a module familiarizing them with oral lesions and diseases. Next slide, please. Here we will see a few patients of mine, just to emphasize, they come from a private practice, and we aim to show how the mouth is part of the body, not forget that, and how systemic diseases as well as local ones manifest in the oral cavity or affect their course and prognosis. And here is a typical periodontal disease patient, 40 years old, presented with severe periodontitis at our clinic, which is the periodontitis is clinically characterized, to remind you, by the presence of dental biofilm at the gingival margin, erythema, edema, bleeding upon probation, and extensive alveolar bone loss, as you see at the radiographic examination. The dental profile of the patient, though, his age, the good oral hygiene, and the dietary habits did not justify his advanced period disease. We suspected DM and asked for lab tests, and the patient was diagnosed with type 2 non-insulin dependent DM, and he was referred to endocrinologist. Here I would like, next slide, please, Donna. Yeah, I would like to mention that in undiagnosed or poorly controlled diabetes mellitus, there is gingival enlargement, bleeding, gingivitis, rapidly progressive periodontitis that may lead to teeth loss. Periodontitis is very closely connected to DM. It's the 6th most common complication of diabetic patients, and the dentist might be the physician who will diagnose the DM first. We also have several other oral mucosal manifestations. I'm not going to get into detail: xerostomia, candidiasis, erosions, burning mouth syndrome, etc., etc. And again, diabetes may alter the occurrence, severity, and treatment response of periodontitis, and vice versa. Here I would like to mention, next slide, please, how gingivitis and periodontitis are risk factors for other systemic diseases like cardiovascular diseases, very strongly associated. Maybe it is very important that the treatment of periodontitis reduces the risk of progression of cardiovascular diseases as well as pulmonary diseases and respiratory infections. We spoke about periodontitis and diabetes. It's very well documented that with periodontitis, we have poorer glycemic control and more diabetic complications, and the opposite, where poorly controlled diabetic patients have more severe and extensive periodontal disease. And also, I would like to mention the association between periodontitis and pregnancy that encompasses both maternal and newborn outcomes. And there is evidence that indicates that pregnant women with periodontitis are more likely to develop preeclampsia and to deliver a preterm and or low birth weight baby. The next slide, I have a collection, let me call it, of patients from my practice who present at our clinic with manifestations of diseases in the oral cavity, systemic diseases like the first picture. You see herpes zoster affecting the trigeminal nerve. It's about 30% herpes zoster manifesting in the oral cavity, and you see the unilateral distribution along the nerve. Then you see ulcerations of a neutropenic patient on the tongue. It's very characteristic, the lack of inflammation because of neutropenia. The next one is a thrombocytopenic patient. You see how hemorrhagic bullae form in the oral cavity because maybe of the trauma caused by the teeth. The lower left is a non-Hodgkin lymphoma arising on the palate of a patient with a Sjögren syndrome. The middle slides, it's two different patients with syphilis. You see the mucus patches of the second stage. They were diagnosed by us. And then another last case of a Crohn's disease of the child diagnosed by his granulomatous cheilitis. Here I would like to point out before I close that the oral cavity is a proportionally small area of the human body, but despite this, it is both a target as well as a starting point of many diseases, local and systemic. It has been calculated that over 800 systemic diseases during the course might manifest themselves in the oral cavity. So in closing, to give us some time for discussion, I would like to say that oral health is directly tied to systemic health. Oral lesions may be the first sign. Could you move the slide, please, Donna? Yeah, oral lesions may be the first signs of systemic diseases. Early recognition will expedite diagnostic processes and initiation of treatment, leading to better outcomes. Skills such as performing intraoral exams, providing basic disease prevention advice, recognizing ill oral health, administering local anesthesia, and obtaining biopsy specimen can bolster the services provided by non-dental health professionals. And lastly, oral health personnel are eager and ready to participate in supporting provision of comprehensive care for your patients. Donna, could you move on? I just would like to thank and give me a minute to thank Jane Barrow for giving me the opportunity to join the programs we have at the Harvard Dental School, to thank Donna for being a perfect colleague and a great friend with who I have shared too much all these years. And I would like to say that for me, this has been a tremendous experience that only makes me wiser, a better person, and a better doctor. Thank you very much for your attention. Thank you.
Thanks so much, Eleana, Donna, and Jane. That was a great talk. I think as I can speak as one of the physicians on the line, that I learned a lot. We're going to open it up for Q&A, so please type your questions, and we'll feed them along to the speakers. I'll start with, I had two questions. The first one is, you make a very convincing argument for the need to integrate oral medicine into more traditional physician training. What have been the barriers that you found? And is there any hope for U.S. physicians? It sounds like you're able to do it fairly effectively in Rwanda. I'm just curious, like what barriers are they? Are there medical schools in the U.S. that are doing this in an exemplary fashion that others can emulate? Any thoughts on that?
Is the question for me or
Anyone?
Okay, I think it's part maybe our mistake, because I don't believe that dentistry is the terminology that we should use. We should use the terminology oral physicians, because when you say a dentist, your mind goes to treating teeth. We don't treat teeth only, so we should maybe correct this. And also, I think we should try harder to reunite the mouth to the body. And like when I was a student at Harvard Dental School doing my specialty, I had to take a lot of modules at the medical school. I think we should try harder and find ears to hear us that maybe a module about oral health should be incorporated at the medical school and start from there, like we did at the UGHC, which was very, very useful for the medical students.
Mhm. And
Sure,
UGHE had visionary leaders, right? They knew before they even submitted the curriculum that it should be a part of it. So that was really a blessing. And so now if the curriculum is already running, the question is how to integrate it. And we've already even started this discussion at UGHE. Where can some of this content go so that we don't get to year 4 and we're starting with just laying the foundation? You know, they should be really experiencing their clerkships by year 4, but we have to almost backtrack a little bit and lay the, you know, the didactic foundation first. You know, what about incorporating a little more dental anatomy into the head and neck anatomy course, right? Or when we're talking about pharmacology and antibiotics, I think why have some attention to things that are a little more, you know, part of the practice of oral health and dentistry. You know, I'm saying incorporated into other courses that are already running instead of having, you know, asking a medical school to find a month to take out of their curriculum to dedicate completely to oral health, which is a big ask, you know, for time. So, yeah.
Great, well, thanks. We're almost out of time, but Ruma had 2 questions that I wanted to pass on. One, any comments on fluoride supplementation in drinking water in lower and middle income countries? How common is that? And is that an important public health intervention? And also, can you talk about task shifting for dental care and oral medicine from more traditionally trained health professionals to dental and oral health assistants?
Mm-hmm. So the question about water fluoridation, it's really a tremendous public health achievement in the last century, right? And as long as you have A, clean water, and B, the right amount of fluoride. So, you know, in many places we don't even have access to water and sanitation. So it's difficult then to try to find water to fluoridate. It also has to, you know, you have to check it and make sure that each day the amount in that water is correct. Because of course you don't want fluorosis. In Rwanda, it turns out that over by the lake, especially in the southwest where Gahaya Island is, and actually a study which was, the data was first found in the National Oral Health Survey. We found a lot of fluorosis in that community that lived on that island. And then UGHE did some follow-up studies with that and published, I think, 2 papers. So, you know, you don't automatically write like a prescription for tablets if you haven't checked the water that they're drinking. You know, if they're in a community that's not fluoridated and you know it's not fluoridated, you could write a systemic prescription. If someone says, I have a well, you should check. And this is for in the US, in Boston. I practiced in Westford for years. And with all the granite up there, we have a lot of fluoride in the water. So if someone came from Littleton or Chelmsford and they said, I have town water and they don't fluoridate, we would test, or sorry, that they had the well, we would test the well water before writing the prescription. So I think it's a little hard to do it in those countries, mainly because of the water, clean water access, and then the monitoring of the right amount of fluoride. The tax shifting question, Jane might like to comment on.
Sure, absolutely. There are many opportunities for task shifting, and we touched upon those briefly in terms of bringing programming into schools where school-based personnel can help, parents can help, community health workers can help. The prevention area is where there is the greatest opportunity for task shifting, and also moving some of the preventive therapies like the silver diamine fluoride and the fluoride varnish applications can be done by a community health worker or within the context of a primary care practice or nursing home or other setting. So there, I know we're out of time, so I'll stop it there, but yes. great question. Thank you.
We'll wrap up, but thank you so much, Jane, Donna, and Eleana. That was a wonderful talk and terrific work. Really amazing stuff.
Thank you.
Thanks so much.
Great.
Thank you for the
having us.
opportunity.
Thank you
Bye-bye.
all. Bye-bye. Thank you all.